Hey, everybody. Welcome to the We Fix Pain podcast, episode number 12. I am with a special guest, Dr. Brian Cole. Dr. Brian Cole is an orthopedic surgeon and sports medicine physician with Midwest Orthopaedics at Rush. Doc, thank you for joining us today, and we appreciate your time.
It's great to be here, and I appreciate you entertaining the concept of having me on your podcast. I look forward to the next 30 or so minutes talking to you.
Yeah, we're flipping the script. Little known fact, I met Doc in about 2012, and first thing I heard was this awesome, smart, exceptionally bright and gifted, talented surgeon on ESPN radio with the Sports Medicine Weekly podcast, which is a weekly staple. I think you've switched to 670 The Score, and it switched from radio to podcast format as this was evolving. And I said, you know what? I just moved to Chicago. I am starting a practice. I need to surround myself with a network of people that are skilled, that will make me look good with my failures. And Doc, you were it.
Well, I guess I could say I failed enough to make anyone feel good. How's that?
That's the ultimate teacher and humbling, right?
Yep.
So let's get some information about Dr. Cole to our listeners. Orthopedic and sports medicine surgeon at Midwest Orthopaedics at Rush. He's professor of orthopedics, anatomy, and cell biology at Rush University Medical Center. He's the managing partner of Midwest Orthopaedics at Rush and department associate chairman and section head of cartilage research, restoration at Rush. And that's why we have you on the podcast. We're going to focus on the subtopic of cartilage and cartilage restoration. Some funny things and some interesting things. He is the head Chicago Bulls team physician. He is the co-team physician for the Chicago White Sox. The funny stuff that I prepped and warned Doc about, he has a 272-page resume. And yes, I looked through it all. That is a mouthful, but there are some pretty significant accomplishments in there. On the fun note here, he's figured out how to clone himself multiple times to get 272 pages on a resume. He figured out how to get 30 hours in a 24-hour day, and he is the only man that Chuck Norris would ever let operate on him.
Things I've probably forgotten more than I can remember. That's a good fun fact.
You've probably never had an introduction like that.
No, I have not.
All right, so Doc, what's your superhero origin story? How'd you end up in orthopedic sports medicine, and how about the niche of cartilage restoration?
So it's a story that it doesn't have to be a long answer, and it's probably something you wouldn't expect to hear, but I can safely say, and having kids that are still pretty young, looking at how they're choosing what they want to do in life, and mine was pretty early. Like I knew I wanted to do something in medicine, healthcare, be a veterinarian or whatever in as early as like 7th or 8th grade. But truth be told, I didn't know what orthopedics was. I was actually interested in, believe it or not, I was interested in psychology, psychiatry, child psychiatry. And then when I went to medical school, I still didn't even know what orthopedics was till I was like a third-year medical student. I was interested in OBGYN, infertility.
Wow.
So it's fascinating because orthopedics was then and is now the most competitive residency to get. Certainly one of the most. And most young people who come through these programs and then they apply to our residency at Rush in Chicago, and the fellows, it's like they were born to be orthopedic surgeons, and then when you read their personal statements, the most common theme is I was an athlete. I did this. I got injured. This person had made a huge impression on me. And I knew then that because what I went through, I wanted to give back and help people and make a difference in their lives and make them better. And to the title of your podcast, We Fix Pain, the reality is that's why I actually was excited to do this with you, because that's sort of my mantra, is that's the business we're in, is actually fixing pain. But staying on topic with your question, the short answer is it was a very circuitous route that was molded by role models that I was exposed to as I evolved through my education. And it wasn't an early decision. The only early decision I ever had was I knew from a very early age that I wanted to be in a situation where I could make a difference in people's lives and help people. As fundamental as that sounds, I think virtually every individual you and I know, they would all, agree that that's largely why they're doing what they do.
Yeah, it's meaning and purpose in life, and the meaning and purpose in life is to make somebody else's lives better. I 100% agree, Doc. So go through your training process. At some point, your orthopedics became from psychiatry and OBGYN, and then you had to decide on a niche, sports medicine, and then you took that niche and made a subfield that was, I think, underappreciated and developing. How did that process evolve into, hey, cartilage restoration is what I want to research, that's what I want to study, that's where I want to end up in this area of orthopedic medicine?
Yeah, so it's a great question because it's relevant to why we're here today. When you go through orthopedic residency, when you love this craft, you sort of, everything was interesting to me. When I did hand, I loved hand. When I did spine, I liked spine. But as I gravitated towards sports, I trained at a really wonderful program in New York called the Hospital for Special Surgery. I had really good role models, and they were very intellectual. They were super skilled surgically. Their patients were those who, like your podcast, they basically had pain and associated dysfunction due to their pain, but were otherwise healthy, but super motivated to get back. And that was stuff that just resonated with me, which is why I gravitated towards sports. So sports medicine, if you will, and that's the field you're in as well, is really nothing more than just working with people who desire to remain active. It doesn't necessarily mean you're dealing with professional athletes in every instance. In fact, that's actually a minority of what we deal with on a day in and day basis. We're dealing with people that desire to remain active or get active again with less pain or no pain, and no dysfunction or impairment. So when I chose sports, I did my sports fellowship at the University of Pittsburgh under the recently deceased Freddie Fu, who was a wonderful, amazing mentor in my life. Yeah, Freddie and I were very close.
I did not know that because I've had several colleagues that were athletic trainers at University of Pittsburgh, and they had affiliated and worked with Dr. Fu, and very high things to say about him.
Yeah, Freddie was an amazing man. And, one of the things that I think you and I are blessed with is, like, who do you think about as your mentors in life? And, I've got at least a dozen that stick out in my mind. And, mentorship is a little like life's smorgasbord, I say. It's not like you have to pick every aspect or every attribute of a human being. It's you may see something that you would like to exemplify, and you may see other things that you'd stay away from. And that's okay. None of us are perfect, but it provides sort of a recipe for, I think, becoming your own individual based upon the things you're exposed to. And I think that's largely why healthcare mentorship is really, really important. And Freddie was one of those individuals who, even to the end, we communicated on a regular basis. He was sort of, like everyone, he was my guy. He was amazing human being. Also, like the others, very skilled, very thoughtful, extremely passionate, academic, intellectual, into translational research. Let's find something that's going on in the office setting. What's the problem? Let's take it to the lab, figure it out, and bring it back in short order. Very pragmatic. And in that fellowship, that was in 97, I remember as a resident at special surgery, just prior to going into my year fellowship, after residency, that the biggest problem we had were young people who had articular cartilage problems, the white glistening cartilage at the end of our bones that provides sort of a slippery cushion that protects the bone, that prevents us from having pain and swelling and locking and catching and loss of motion. When that's normal, we do well. When it's not normal, which is unfortunately a large percentage of the population at some point in their life, we had no solutions then. So, Dino, what we used to do is just put a camera in the joint and take a shaver and clean off edges and so forth, and the person would feel better, incompletely so, for a short-lived period of time. And that was pretty much it. The only solution we had at that time was what Dick Stedman had popularized out of Vail, Colorado, which was a procedure called a microfracture, where you just clean off the bone and poke a bunch of holes in it and bank on the fact that the body has some healing response. And that was profoundly unpredictable, often delivering no response, but when it did, it was maybe incomplete and short-lived. And that was it. So you either clean it out, reduce some of the biologic the elements of what's in the joint, reduce the swelling, maybe reduce some mechanical symptoms, and patients would be back with symptoms, and you have to just tell them to deal with it. So that was the genesis of when I was a fellow in 1994, Carticell, or the Genzyme procedure, which is a cell-based cell transplant, and the osteochondral autograft, which was when you take a piece of bone and cartilage from one part of the joint and transfer to another, almost like a hair plug transplant. Those are the only two things available in addition to microfracture and a cartilage debridement, where you go in the joint and clean it out. So that was it, and that was all new, and we really didn't know where to put it. And the thing that I've always been most interested in is in decision making. And residents and fellows all are fascinated by, I want to do something, but I was always of the mindset, I just want to figure out how to do it and how do you make the best decision with the best available evidence. We'll all learn how to do something. Doing something is actually not that hard. Surgery is not that hard, quite frankly. It's really about the decisions you make based on the data you have and understanding what patients are looking for. And we're not here to stomp out disease. We're here to actually fix pain and make people feel better, right? And you don't have to get rid of disease to actually achieve that endpoint. You got to figure out the best way to manage it. And my general paradigm is what's the least amount I need to do to make someone be well, to feel well, so that they can meet their primary objectives. And cartilage repair was just in its infancy. And when I came to Chicago under Bernie Bach, who was the then fellowship director, also recently retired, who's an amazing individual, just enabling. He just brings in people better than him and around him. That's always been his mantra, and that's something we've continued here at Midwest Orthopaedics at Russ in Chicago. Created the Cartilage Restoration Center, which was the first in the world. That was multidisciplinary. We had biochemistry, PhDs, postdocs, anatomy experts, people in tribology, which looks like the wear of bones and cartilage, and even joint replacement. And we sort of assembled a team of people that were really interested in this problem and how you delay or maybe even prevent joint replacement by providing alternatives. And we just evolved. We evolve as the knowledge comes in and figure out where the stuff fits, and have been involved with at least 10 FDA trials, have brought 3 or 4 new products. Doesn't sound like a lot, but the burden of getting to the FDA is brutal. Products to market over my 25 years, and we have 2 or 3 on the horizon. So we're always learning, always evolving, always getting better, but we're in a far better place now in that sort of 75% quartile, if you will, of getting people better for problems when I was a resident in 1997, which was in the 5% or less. Wow. Getting people better. So like that's the best part of my career, even though I love doing some of these other things. I take care of, shoulder, elbow, knee, baseball players and collision athletes and things of that nature. When you look at what's happened in orthopedics, this has had one of the biggest impacts on changing, population health is managing cartilage without metal and plastic.
Doc, it sounds like, to recap this, it was the perfect storm for you. Right time, right place, right clinical questions, and right where is this field tracking? Because I think right about that time, late 90s, early 2000s, we're starting to see the folks that they want to stay active for an extended period of time. And these injuries were keeping them from quality of life, basically. So sounds like you were in that right time, right place.
There was a white space of missing technology, but technology that was being presented. And you're right, at a time in our lives where people were living longer, but not always with good health. And you and I strive, I imagine, to live as long as we can, but neither of us would want to do it at the expense of living with poor quality life. Arguably living in pain and having physical impairment, I'm not sure people necessarily want to sign on to that, even though they get more chronology in years, right? So The issue is how do you keep us feeling good as we age and stay active, and how do we provide solutions that do that? And that's really the crux, I think, of sort of orthopedic or musculoskeletal medicine. And you don't need to be a surgeon. You could be just like you. It's, providing solutions to people that keep them feeling right as they move through life.
Doc, I'm going to back up a second. You said some really cool things, but there's some average listeners that listen to this podcast in addition to some medical folks. So what happens to the body when we have a cartilaginous lesion, whether it's articular A or B, like a meniscal lesion? What actually happens to the body in terms of the injury itself and then the degradation process? Because it sounds like your procedures and your research was evolved to slowing the rate of deceleration, where a patient goes from somewhat functional to I have really bad osteoarthritis. What happens to the body during that time?
So for your listeners for the episode, I think it's important to sort of think about cartilage. There's 2 types of cartilage, lots of cartilage, but 2 main cartilage that relate to what you and I are talking about. One is the articular cartilage and the other is the meniscus cartilage. Meniscus is generally pretty specific to the knee. Articular cartilage is any joint that moves. So we have articular cartilage on every joint surface in our hands, fingers, shoulders, elbows, toes, everywhere we have articular cartilage in any joint that moves. And what it provides is a protective surface over the ends of our bones. And when the cartilage starts to erode or it gets damaged, it doesn't have any intrinsic ability to heal. So unlike a fracture where you break a bone, the cartilage, once injured or degenerates, it doesn't get replaced by the body unless you do something to make it happen. So while we have lots of things in our bodies that heal, you cut yourself, your nails get broken, you get a laceration, you break a bone, that stuff will heal because that's how our bodies are made. When cartilage is injured, it doesn't have that capacity. So the natural history of a cartilage injury in some instances is one of progression. And cartilage injury is not really the way you and I think and our listeners think about arthritis. Arthritis is sort of a full-blown loss of cartilage in a joint that leads to swelling, pain, predict the weather change, things like that, load pain, can't do the things you like doing, your world shrinks around you. That's what arthritis is associated with, but those same findings can actually happen when you have just a little bit of cartilage loss. So if you can intervene early, you can A, stomp out symptoms, fix the pain, get them functional, and B, maybe change the natural history, which is one that is generally not favorable for someone who starts early on the spectrum if you catch them, which typically leads to progressive disease over time. And so that's the nature of the meniscus. Cartilage is another one to think and talk about. Also, meniscal tear is one of the most common things we deal with. And when someone loses their meniscus, there is the stage, the die is cast for many to develop arthritis as well. But people should think about this as a spectrum of sort of peeling paint. The paint bubbles on the wall, you lose a little bit, doesn't look too bad. Then it gets worse, and then the wall starts to deteriorate like the bones would start to deteriorate, and that becomes a very irreversible situation where the solutions get harder and harder to deploy and actually be successful.
I like that analogy with the peeling paint. I never thought about it that way, and I think that would make sense to the right demographic of patients because guess what? We all have paint in our houses.
Yep, so, we do.
All right, so let me ask the follow-up question to that. So what happens when we have a cartilage injury and lesion? The follow-up to that is, how do we assess these out? Is there some things a patient will say in a history or an exam, or some things that you find on physical exam that lead you to you have a cartilaginous based problem? Because sometimes in clinical practice, it's a little hard and patients can be all over with their history. Are there signs that lead you to they suspect they have the issue?
Yes, being a doctor is actually pretty easy if you stick to the basic principles. So a patient will provide a history, the physical examination, and then there's some data and benefit of x-rays and maybe an MRI. And you can see I'm sort of downplaying the last 2 points because this is something that you and I can figure out by walking in the room. You kind of know. And and I think it's important for patients to understand that we don't have to necessarily rely on high-level technology as long as you understand disease and what symptoms are caused. How did it start? Was there a specific mechanism of injury? And interestingly, there isn't always a specific mechanism. People will search. When I ask patients, how did this start? Did you have a traumatic event? And I see their eyes look to the left or the right, and they're thinking about it. And I'm like, no, there obviously wasn't, but they're trying to find something because everyone thinks that they were responsible for their problem. And the reality is most cartilage problems are degenerative. There's a great quote from Atul Gawande, who's written a number of books. And one book I highly recommend reading if you're interested in this kind of thing is called Being Mortal. And he talks about how we're sort of all rotting from the inside out. And that's true. Our bodies are, like it or not, every day we live, we start to have some degree of deterioration. And arthritis has to start somewhere. And the day you lose a little bit of cartilage is not the day you start to become symptomatic. But once it reaches a certain threshold to cause symptoms in some, but not all people, they'll typically say, look, I'm getting some weight-bearing pain. I've had to reduce the activities that I do because the pain gets elevated. I'm getting some swelling in the knee. For example, they may say my knee is actually giving way because of the pain and the swelling. I don't have a lot of strength or lift. I might even have mechanical symptoms of catching or locking. The spectrum is broad. These are the things that make it better. I reduce my activities. I take an anti-inflammatory, Motrin, Aleve, Advil, whatever. It feels a bit better. And here I am. What do you think? And I could smell that in 15 seconds, by the story, and it's fairly consistent. And then the physical exam could often be actually normal. A patient can have a completely normal physical exam without any objective findings in the office, yet have all those complaints and have a real cartilage problem. X-rays can actually be normal in the early phases. And so someone say, well, you got to get an MRI. And I don't know a human being who's ever felt better after getting an MRI when they get out of the scanner, right? But patients have this fascination, this dependence upon the technology that you're a lesser doctor if you don't get an MRI. And to me, that's just technology over reason. And I've learned that sometimes it's not even worth trying to explain it to patients, then I just get it. But an MRI is helpful as a pre-surgical tool in many instances, and maybe a little bit prognostic. Right? Yeah, maybe a little bit prognostic in terms of how they respond to non-surgical treatment, but it also creates a lot of noise. The findings in MRI create a tremendous amount of noise that you have to re-educate, reorient the patient because they start focusing on the MRI reading, which may have zero relevance to what's happening. As I say, you can get an MRI of any part of your body today. Everyone listening to this episode could do that. And I guarantee you they will have significant findings that have no clinical importance. Everyone's got a bulging disc. Everyone has arthritis and cartilage loss in various joints. Everyone's got tendon changes, but they may have zero symptoms, zero. In fact, that's what's most common. So it can be helpful if everything non-surgically fails and you start thinking about surgical intervention if you can't, or it could be helpful if you really don't know the diagnosis, or if you're not entertaining surgery. An MRI, for example, could be helpful to predict who will respond to non-surgical care favorably and who will not.
Doc, you bring up an interesting point, and my training was initiated as an athletic trainer in the late 90s and early 2000s. Our thought process about how to utilize the MRI or how to educate or re-educate on the MRI has completely changed in this 20-year cycle. That's for sure.
Yeah, there are people who make their careers on being excellent radiologists, when it comes to research and cartilage regeneration, a good quality MRI can be useful as an anatomic endpoint. When it comes to research in rotator cuff repair, if the endpoint is I want to know if the tendon is healed down to bone, we utilize MRI or ultrasound to prove that. So it can be very useful in that regard. But there's two acronyms which I love. One of them is called BARF, and the other one is called VOMIT. Are you familiar with those two?
Baseless application of radiological findings, right, and victim of modern imaging technology.
You got it.
The person I heard that from is a neuroradiologist, and neuroradiologist.
That's a guy who's that's an individual who's got a lot of humility because the baseless or the brainless application of radiologic findings and a victim of modern imaging technology, BARF and VOMIT. And again, the days in my office, if you stayed a day in my office, many of my patients come in with their MRIs in hand, and I got to talk about a lateral tear in the shoulder, how it doesn't need to be fixed, how they have some subcondylar edema, some fluid in the bone, that they're not going to end up with a knee replacement. I mean, my day is spent discounting findings as much as it is actually helping them help provide the reassurance and the little bit of treatment people need to fix their pain.
Yeah, that's the doctoring part of it. That it's a reality check when you start, looking back at those cases earlier in your career. Like, I could have said something differently or managed it differently.
Yep, 100%.
Let's morph and transition a little bit. So we're going to try to classify different patients into different categories, and you're going to help us through that. So who is the patient that they have a cartilaginous issue that, hey, we see this patient, they need a procedure, cartilage procedure, or which type of cartilage procedure? Who's the surgical candidate?
So most people with cartilage problems don't need surgery. But people who become symptomatic with the symptoms I outlined of swelling and achiness and weather-related changes and weight-bearing pain, maybe locking, catching, or giving way, we'll stick to the knee for now, the most common place, they need treatment. Treatment can fall into one of two categories, non-surgical or surgical. Non-surgical treatment does have a role, something as simple as cortisone injections, platelet-rich plasma, hyaluronic acid, weight loss, physical therapy, orthotics, supplements, glucosamine sulfate, undenatured type 2 collagen, black pepper extract, all turmeric, turmeric, vitamin D. There's data to support lots of things that can reduce symptoms. Again, I'll keep going back to you, fix the pain. That being said, there are many people who have conditions that cannot be remedied to provide a satisfactory pain response and functional return that need surgery. So the surgical component, these are typically younger patients who are age inappropriate for knee replacement. number one. Number two, they typically do not have advanced bone-on-bone arthritis. And that's important because there are people who will listen to your podcast who will think, well, I was told I need a knee replacement. I'm 65 years old. I'm bone-on-bone. I'm not getting one. I hear you can transplant cartilage. The bad news is that, no, you're not going to be a good candidate for a cartilage transplant. The good news is we already have a good solution for you if you meet the criteria, and that's a joint replacement. So you don't have to search for something magical when you're bone-on-bone arthritis and you're age appropriate. So for the age inappropriate patients, meaning age inappropriate for a replacement because they will then potentially need a second or a third one, and plus they don't have advanced disease, so they're not even candidates anyway because they don't respond favorably to replacement. That's my population. That's the sweet spot. And that can range from people who are 14 years old to 50 to 55 years old, depending upon the extent of disease. And then we deploy a treatment algorithm that's based upon the available technologies. And look, if patients are, if there's individuals who really want to learn about this, and there's no way we can do it justice on this podcast, I'm just going to, just give a little plug about an educational site, which is my website, because there's so much educational content there. It's briancolemd.com. Pretty simple, right? And briancolemd.com, right?
I'll link that in the show description and notes.
Yeah. So I don't want to give a whole, a compendium on what it takes to manage cartilage problems, but we basically, when it comes to surgery, it ranges from arthroscopic debridement and clean out, which should not be lost, that simple things can work. We do that in high-level athletes all the time. The number of professional or college or other athletes we operate on just with simple things like just cleaning out the joint it makes everything else pale in comparison. There's marrow stimulation or drilling, where we drill holes to create scar cartilage for smaller defects. There's autogeneic tissue, where I can take a plug and bone of cartilage from one part of a joint and transfer it to the defect. Then there's cell-based technology, where I can take a small sample of your cartilage cells, take it to a laboratory, grow the cartilage, put it on a collagen membrane, and literally just put a new piece of paint in the area that's missing cartilage. And there's allograft tissue, which is where we use donor tissue. It could be sheets of cartilage, it could be sheets of cartilage with a little bit of bone. It could be a full-on piece of cartilage and bone, fixing areas of 35 to 40 millimeters in diameter in multiple spots in the knee with cartilage transplants called osteochondral allografts. And now we even have synthetic options, such as the use of coral, that have developed, synthetic implants that we can now put in for, coral, literally coral that's medical grade in plugs that we can treat patients with widespread arthritis with that.
Is it because it's a scaffolding?
That's exactly right.
Chemical properties.
Exactly right. It's a biologic scaffold that induces your body to heal. All of our bodies want to heal. We just need to figure out a way to harness its ability to heal. So these scaffolds actually can do just that.
Doc, it sounds like on the surgical aspect, there's a menu of procedures, and you really try to categorize who would most benefit. And there's an algorithm that sounds like you guys have been working on to get there. I'm going to flip to the second part of it. So sniper specific, one shot, one kill. Who is the candidate for the orthobiologics? Skip surgery, not yet. Orthobiologics. Who's that candidate?
So our listeners will know what we're talking about. An orthobiologic can be anything that modifies the biologic environment. We'll say that's generally not surgery. So so we do biologics and surgery, but let's just say the orthobiologic as a standalone procedure or as an adjunct to surgery involves things that are not currently they're minimally manipulated. They're not profoundly regulated by the FDA. And they are not, I want people to understand, take this home, they are not based upon the cells that are in there, nor regenerative capacity. So that's really important for people to take home. We have a number of things we can inject that people would historically called stem cells or other that have nothing to do with the cells themselves, but rather provide growth factors to modulate the environment to change the way people feel. Again, I could say it 100 times during our recording here. We fix pain. You have it right, Dino. You have it absolutely correct. So all you have to do is to help people feel better. You've got to get rid of or reduce their pain so they're satisfied for as long as possible. And so that they don't have to shrink their world, they can meet the demands of their desired world rather than shrinking it to, with adaptations. You're expanding the way they feel, improving the way they feel by reducing their pain so they can do more in the world they wish to live in. So orthobiologics can do just that. They can modify symptoms. It could be hyaluronic acid. Even I would consider cortisone an orthobiologic. It could be platelet-rich plasma, which we've studied extensively, which provides platelets with growth factors to reduce inflammation and pain. It could be bone marrow aspirate, where we take bone marrow, spin it down a centrifuge. Yes, they provide stem cells, a few of them that, if in a test tube, could be driven down a pathway to create cartilage, but that's not how we use them. We use them as little growth factor warehouses and production facilities to produce growth factors to change the way people feel. We use adipose tissue, lipoaspirates, fat that have stem cell, or more importantly, cells that produce growth factors. We can use amniotic tissue, which does not have cells typically, but has growth factors and lubricants and other factors that can make people feel better. So those are orthobiologics. The take home is that they're not heavily regulated by the FDA. They are not typically covered by insurance or third-party payers, so it's out-of-pocket expense. There's a lot of misuse of these things. There's more importantly, there's a lot of misperception on what they do. They do not regenerate when used as injections. So the things you see that are advertised, the things you see that are marketed, the way when you drive out to a O'Hare or any other major airport, these billboards, I would just say buyer beware. There is a tremendous amount of misguidance and misperception. Doesn't mean they don't have value, but they are not working by regenerating tissue, period. They can help tissue regenerate when used as an adjunct to surgical procedures, by the way. But when used in and of themselves, they do not regenerate tissue, period.
Gotcha. And going down the list of options, one shot, one kill, sniper specific, who's the candidate? Skip the regenerative stuff, skip the surgical procedure. They're good old-fashioned guided physical therapy. How do we differentiate that patient?
Typically, patients who have loss of extension, quadricep atrophy, who have anterior knee pain with or without cartilage problems are your best candidates for physical therapy. Motion loss is the number one accelerator of symptoms, and if you can restore extension especially, and quadricep strength, and then general hamstring and core strength, those patients can be responsive to physical therapy. That's people typically with anterior knee pain, followed by people with medial or inner-sided knee pain who have sort of somewhat bow-legged. You can strengthen the outer side of the knee, the leg, the core to offload, reduce the load that the joint feels. Most symptoms are load-related. Load goes up in a knee that can't get fully straight or that has muscle weakness around the knee or upstream from the knee.
Yeah, typically I'm working from a manual standpoint to increase end range extension exactly for those purposes. That's the common pattern I've seen over 20 years, knees lacking end range extension, and as a result. And then, like I said, up and down the chain, the hip and the core can buffer. Some of that lower extremity kinetic chain is instituted by the foot hitting the ground. So controlling how the foot places the ground, 100% concur, Doc. Last questions. This is your term. I'm calling it the Cole terminology. You should make a t-shirt because somebody will. Skillful neglect. Who's the candidate out there we have to leave alone? Like you don't need therapy. You don't need surgery. You don't need regenerative medicine. We are skillful neglected. We're going to watch you, leave you alone. And if life throws you a curveball, come on back and see me. Who's that patient?
Skillful neglect can be used for any patient who walks in my office for the most part. Mostly, I'm in the business of education and providing reassurance. If you really ask a patient why they are there, they are often concerned that they have pain and maybe they've been told they have a problem, that if they don't do something today, they'll end up in a different place later on that can't be managed. So they have this sense that there's a preventative aspect of treating early, when in fact, if they were given permission to coexist with their problem, they would actually do so. But they have to understand that that's okay to do. Pain is not a deal breaker. Pain is a symptom that people get when they're typically placing higher physical demands on their bodies. If they can, and pain in the way people manage pain, whether they're a catastrophizer, they can't handle it, they have withdrawal responses, they have hypersensitivity, that's a real thing. Versus those who have a little bit of discomfort, but they're overwhelmed with concern about not doing something to get rid of it. So in my office, even as a surgeon, that's mostly what I still do. But that may not be good enough for a certain population. So knowledge and understanding of the natural history of a problem is the most important thing that you and I can have. allowing patients to live with their disease, which they're already living with anyway in most instances, but just don't know it because they have no symptoms. The level of disease that surrounds you and me is an epidemic, but they just don't know it until they get symptoms and then get an MRI and they're told that they're sort of rotting from the inside out, right? But if you think about, there are 7 million people over the age of 65 that have a rotator cuff tear. We only operate on, in total, about 500,000 in all ages. So you have to ask yourself, where are the other 6.5 million plus people who aren't getting surgery for the rotator cuff tear? They are living perfectly fine with no symptoms and have no idea that they have a tear because they're adapted. And then when they become unadapted, they decompensate. They can actually go to you for physical therapy. They can come to me for a cortisone injection, and they can be made to adapt. The same thing is true for osteoarthritis. So we don't have a lot of data that says if you neglect arthritis, that allowing someone to be active will make it worse. So the first thing I tell a patient is, look, if you are armed with the knowledge that it's safe to remain active despite having arthritis, could you do it? I'm giving you permission to do it. And they say, look, that's great. It gives me some confidence that I'm not going to hurt myself. But no, my symptoms are too much for me to tolerate. I've had to shrink my world to meet the demands of my knee. Then I say, okay, let's do something. You need treatment. And that treatment can be non-surgical or surgical. So skillful neglect, in theory, can be applied to almost any human being in the musculoskeletal space for the things that I deal with. I'm not talking about a femur fracture or a clavicle fracture with displacement, or an acute tendon tear or laceration of a tendon or a ligament, or maybe an ACL tear in an otherwise active patient. I don't want people to misunderstand what I'm saying. I'm talking about the most common conditions that bring people into the office, which are back pain with herniated discs and knee pain or hip pain. There are ways to coexist with this problem. That's skillful neglect, and that requires education. And like it or not, I don't think you hear that very often from a surgeon. And as I said early on, people who are sort of earlier in their career they love the ability to do something, because when you do something and it's technical and you make someone feel better, that's a feedback loop that provides great satisfaction. But one should never lose sight of the fact that, it's okay to do nothing in some instances and simply get a better understanding of your problem. But truth be told, there are many conditions that that's not enough for people. And this neglect aspect, you still need the skill, but maybe you can't neglect it any longer and you have to do something to make people feel better.
Yeah, and I think you hit the nail on the head. The number one reason why people see the doctor in our neck of the woods, neuromusculoskeletal, is reassurance, right?
That's right.
I want to know what's going on. I want you, like you said, I'm going to encourage you to be physically active up to tolerance. And the second thing is there's something inhibiting them from something they want to do, which also creates pain as well. And if we could take care of the reassurance part, we've done 50% of the battle.
Yeah, and then they may want to feel better, which is fine. And that's okay. I mean, people,
Yep.
we have ways to fix the pain.
Yep.
And and I know, doing what you do day in and day out, you can do without surgery. But there's some things that surgery is great. I mean, what I do is amazing for people. What I can do, what my colleagues can do, you can change someone's life with surgery, but I can actually change more lives with the conversation we're having right now, to be honest.
Yep. You can reach more and educate more, and that's doctor, teacher, right? Fundamental
That's right.
at its core. Hey, Doc, you're a busy guy, so I want to say thank you for your time. I want to give you an opportunity. What closing thoughts do you have on the topic, or closing thoughts from your years of experience? And then how can people reach you? So let's close this down with those two questions: closing thoughts and how can people reach you?
Yeah. So, I think you've provided an opportunity, a venue to share some of the things that I think about a lot. You can tell I have a lot of passion for this. None of this is scripted. I would say that from a physician's point of view, that the greatest satisfaction comes from still the initial reason why I and you went into healthcare and medicine is to make a difference in someone's life. And that doesn't always have to be something that has to be done technically. It can be knowledge, education, and there's lots of ways to succeed. And my general philosophy is, let's do the least amount necessary, minimize the risk and the variability of the outcome by the solutions we execute and choose. From a patient perspective, knowledge is power. And I think gone are the days where patients should just listen to a physician blindly and say, well, he or she knows a lot more than I know, so I'm just going to listen to the doctor. I don't think that's a good idea, quite frankly. I think a better idea is to certainly not, on the one hand, just go to the internet and believe everything you read, because that's very problematic, but don't be afraid to ask the hard questions. I always tell my patients when they leave the office, what I've told you should make sense. I'm not trying to sell you anything. I'm like a waiter, and I'm going to tell you all the things that are on the menu, and you get to pick what works best for you, because there's more than one thing here that might be the right answer. And that's what that is just consensual decision making. So as a patient, keep control of all your data, because it isn't a universal health system where everyone has access to everything. So you keep control of it so that when you need it, you have it for a visit. Write down your questions when you go to see the doctor. And by all means, do not be afraid to ask hard questions. And if the physician feels if you feel that physician is being threatened or inconvenienced, go to another doctor. And I don't have any problem saying that. Go see someone else until it feels right. Healthcare is a virtual disaster right now. It's hard to get in. It's hard to see a doctor. It's hard to get access availability. I get it. The system is incredibly complex. The insurance side is brutal. What you're going to pay, what your copay, what you're out of pocket. It's a really tough thing to navigate. So that leads to the last point, which is how do you reach me? I have found that being available through digital means has really created an environment. If you read my reviews, you will uniformly hear or see that patients are satisfied because they had access. They could email through a direct, easy to use fashion portal. They can text in a compliant way. Providing access, it rarely, if ever, gets abused. And patients just knowing that they can get in touch with you, it makes all the difference in the world. So me being available and doing it through advanced practitioners who work directly as a team has made the difference between providing a good product, a good service to people, and not giving the perception that you're not available or that you're hands off. And I think that's really important. So, if you go to my website, and that's how you would reach me, briancolemd.com. That's, I'm at Midwest Orthopaedics at Rush. I'm the managing partner of a very large orthopedic group where I think we have always been in the top 5 in the country. And I would go to any one of my colleagues for care. And we cover every specialty in musculoskeletal medicine. And all of us have, websites through the portal, but mine is pretty simple, briancolemd.com. And there's a ton of educational content there. And I would encourage people, if you do anything else, just go to the educational videos, the patient educational video section, which I took a lot of time to prepare. These are vignettes that talk about patient care and then talk about specific conditions. But it talks about how you can be your own advocate, whether you come to see me or someone else, how to get the most out of the experience, because there's a lot of inefficiencies and there's a lot of noise in the healthcare system. So you got to figure out how to best navigate that.
Doc, thank you so much. I'd like to vouch personally for Dr. Cole. He's not paying me to say this. My patients in Chicago, when I practiced there and lived there, they had an excellent experience. And it wasn't just Dr. Cole, the physician assistants, the scheduling, the staff, everybody was treated friendly. There was good coordination. I got notes and information back so I could, kind of reciprocate and be on message with Dr. Cole and what his staff said. The physician assistants were timely in communicating, which patients appreciate. And I have nothing but positive experiences from my patient over and over and over again. So thanks you for
Dino.
taking care of my patients. Thank you for graciously giving us some time. Look forward to catching up when I'm back in Chicago sometime, Doc.
Yes, please do. And all the best to you.
Thank you, Doc. Appreciate it.
Bye-bye now.